Hello, I am Mansi Gawali, one of the medical students.
Okay.
So today I am going to examine your thorax and lungs. So what is your name?
My name is Mr. Gawali.
Okay. And what is your age?
I'm 40 years old.
Okay. So we'll start by examining your posterior thorax.
Okay.
Before examining the posterior thorax, observe the rate, rhythm, depth, and effort of breathing. Listen for audible sounds of breathing. Now listen and count number of breaths per minute. Normally, a healthy resting adult breathes quietly and regularly about 20 times a minute. Inspect the neck. Is there any contraction of accessory muscles, namely the sternocleidomastoid and scalene muscles, or supraclavicular retraction, suggesting a respiratory difficulty? Inspect the patient's color for cyanosis or pallor by looking at the shape and the color of fingernails. Look if the thorax is symmetrical, how it moves, and is there any bony deformity. Now palpate the chest to focus on areas of tenderness or bruising. Carefully palpate any area where the patient reports pain or has visible lesions or bruises. Note any palpable crepitus, which is crackling or grinding sound over the bones, joints, or skin with or without pain due to air in subcutaneous tissue. To test chest expansion, place your thumbs at about the level of the 10th rib with your fingers loosely grasping and parallel to the lateral rib cage. As you position your hands, slide them medially just enough to raise a loose fold of skin between your thumbs over the spine.
Will you please inhale now?
Watch the distance between your thumbs as they move apart during inspiration and feel for the range and symmetry of the rib cage as it expands and contracts. This movement is sometimes called lung excursion. To detect fremitus, use either the ball or ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand.
Repeat 99 when I'll ask you for.
Identify and locate any areas of increased or decreased or absent fremitus. If fremitus is faint, ask the patient to speak more loudly or in deeper voice.
Okay, you can stop now.
Okay.
Continue the examination by percussing the chest in systemic manner. While the patient keeps both arms crossed in front of the chest, percuss the thorax in symmetric location on each side from apex to the base. Percuss one side of the chest and then the other at each level in ladder-like pattern. Hyperextend the middle finger of your left hand, known as pleximeter finger. Press at its distal interphalangeal joint firmly on the lung surface to be percussed. With a quick, sharp but relaxed wrist motion, strike the pleximeter fingers with right middle finger called the flexor finger. Aim at your distal interphalangeal joint. Your goal is to transmit vibration through the bones of this joint to the underlying chest wall. Listen to the intensity, pitch, and duration of the percussion. The normal lungs are resonant. Next, ask the patient to breathe out and use percussion to identify the lower level of diaphragm. Holding the pleximeter finger above and parallel to the expected level of dullness, percuss downward in progressive steps until dullness clearly replaces resonance. Auscultation is the most important examination technique for assessing airflow through the tracheobronchial tree. To auscultate posterior thorax, use diaphragm of the stethoscope. Use the ladder pattern suggested for percussion, moving from one side to other and comparing symmetric areas of the lungs. Listen to at least one full breath in each location. Listen for the pitch, intensity, and duration of the inspiratory and expiratory sounds. Normal vesicular breath sounds are soft and low pitched, heard during inspiration and first third of the expiration. It is heard over most of the lungs.
Now we'll examine your anterior chest.
When examined in the supine position, the patient should lie comfortably with arms somewhat abducted. For inspection, observe the shape of the patient's chest and movement of the chest wall. Note any deformities or asymmetries. Palpate the anterior chest wall for identification of tender areas, assessment of bruising, sinus tracts, or other skin changes. For assessment of chest expansion, place your thumb along each costal margin, your hands along the lateral ribcage. As you position your hands, slide them medially a bit to raise loose skin folds between your thumbs. Ask the patient to inhale deeply. Observe how far your thumbs diverge as thorax expands. Feel for the extent and symmetry of the respiratory movement. For assessment of tractile fremitus, use the ball or ulnar surface of your hand. Fremitus is usually decreased or absent over the precordium. Next, percuss the anterior and lateral chest, again comparing the both sides. The heart normally produces an area of dullness to the left of sternum from third to fifth interspaces. Percuss for liver dullness and gastric tympany. As you percuss down the chest on the left, the resonance of normal lung usually changes to the tympany of the gastric bubble. For auscultation, listen to the chest anteriorly and laterally as the patient breathes with open mouth and somewhat more deeply than normal. Compare the symmetric areas of the lungs using the pattern suggested for percussion and extending it to the adjacent area if needed. Listen to the breath sounds, noting their intensity and identifying any variations from normal vesicular breathing. Breath sounds are usually louder in upper anterior lung fields. Bronchiovesicular breath sounds may be heard over large airways, especially on the right. Identify any adventitious sounds, time them in respiratory cycle, and locate them on the chest wall. Will you please say 99 now? If indicated, listen for transmitted voice sounds.
Take deep breath in and out with open mouth and as quickly and completely as possible.
Okay.
Listen over the trachea with the diaphragm of the stethoscope and time the audible expiration. Try to get 3 consistent reading, allowing a short rest between efforts if necessary. This test assesses the expiratory phase of breathing, which is typically slowed in obstructive pulmonary disease. With one hand on the sternum and the other on the thoracic spine, squeeze the chest. By AP compression of chest, you can help to distinguish a fracture from soft tissue injury.
Is it painful?
No.
Okay.
Now record your findings. In this way, lungs are examined. Thank you.